Dr. Linda Shore-Lesserson, who will provide our keynote address today. Dr. Lesserson's title of her talk is How Does Avoiding Perioperative Transfusion Improve Clinical Outcomes in Cardiac Surgery? So Dr. Linda Shore-Lesserson is the president of SABM. She's also a professor of anesthesiology and the director of Cardiothoracic anesthesiology at the Zucker School of Medicine at Hofstra-Northwell, North Shore University Hospital in Hempstead, New York, in the US. Dr. Shore-Lesserson is, again, professor of anesthesiology at the Zucker School of Medicine. She received her medical degree from the University of Pennsylvania, and she's a diplomat of the American Board of Anesthesiology and of the National Board of Echocardiography. She's a clinical and academic cardiac anesthesiologist who is the past president of the Society of Cardiovascular Anesthesiologists, and she currently serves on the board of directors of the National Board of Echocardiography. As an educator, Dr. Shore-Lesserson has been program chair for numerous national meetings, and she's currently the general chair of the New York Society of Anesthesiologists Postgraduate Anesthesiology Annual Meeting. She is the third vice chair for the ASA Annual Meeting Oversight Committee. In the cardiac community, Dr. Shore-Lesserson is a fellow of the American Heart Association, and she assumed the role of the chair of Surgery and Anesthesia Council of the AHA in the fall of 2023. Her other positions include being the anesthesiology lead working with the Society of Thoracic Surgeons and the American Society of Extracorporeal Technology on an interdisciplinary project called Best Practices in Perfusion Management. As past chair of the Committee on Patient Blood Management for the American Society of Anesthesiologists, she stays active in that medical specialty, and she now serves as president of SABM. Her research interests include the field of hemostasis and thrombosis as it relates to cardiovascular disease. And the results of Dr. Shore-Lesserson's research have been published in high-impact peer-reviewed medical journals, and she also lectures frequently at national and international scientific meetings. And we are so lucky to have her speak to us today. Thank you, and take it away.
Well, thank you very much, Kelly, for that warm introduction. Thank you, Kelly and Dick and Nathaniel, Dr. Usoro. Thank you for this warm invitation. First, I'd like to take a few seconds to just embrace this collaboration between the BMSS and SABM. This has been a long-standing relationship. We are so proud to be here. And I'm so happy to be participating in the SABM session alongside these fabulous talks that we just heard. So it's my honor to be here, and I invite everyone to join us at SABM, our next meeting in September of 2025, which I will share with you in a few moments. So I'll share my screen and begin speaking now about patient blood management and outcomes in cardiac surgery. And this is a topic that's near and dear to my heart. I actually began my interest in blood and blood management years ago when I was studying heparin and protamine and antifibrinolytic agents and antiplatelet drugs. And it wasn't until about 15 years ago that the interest in patient blood management became focused on anemia and anemia management preoperatively. And it's so critical, especially in heart patients, that we manage iron deficiency. So this has now become a true passion of mine that manages to coexist extremely well with bloodless medicine and patient blood management. So I'd like to start by introducing the guidelines that were published a couple of years ago by first author Dr. Peter Tibby, who is a past president of SABM. These guidelines inform the practice of patient blood management. They span the whole timeline of a cardiac surgical patient's presentation to the medical system. They begin with anemia management. They proceed through cardiac surgery, which is quite complex, especially from a blood management perspective. And they predict outcomes in cardiac surgical patients. So many of the recommendations I will make come from this guideline and stem from evidence-based medicine. We all know the definition of patient blood management. Many of us here today helped to create this definition of a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing, preserving a patient's own blood while promoting patient safety and empowerment. There's a reason why the word patient is mentioned 3 times in this definition, and it is clearly for the benefit of the patient that we proceed to practice patient blood management in cardiac surgery and in all of our medical encounters. So these are the ways in which we help the patient in cardiac surgery. We have anemia management. We have a lot of coagulation defects, and this is part of our coagulation management, a coagulopathy management that we exercise during cardiopulmonary bypass and a cardiac surgical admission. We also have pharmacologic and technological adjuncts to our surgical management. We have algorithms. I like to call them bleeding algorithms because we are trying not to transfuse. So I try not to call them transfusion algorithms. And the interesting part about these are that they now include pharmacologic agents, not blood products. So we are now achieving more closely the management of cardiac surgery patients without blood. And finally, the technological aspects of the cardiopulmonary bypass circuit, which I probably will not get into today in the interest of time. Speaking about anemia management, this is something that I think all of us are very invested in. And the data in cardiac surgery are a little more recent than in the general surgical population. So I'll go over a few of the studies that have led us to understand that anemia management is critical for the management of cardiac surgical patients to have optimal patient blood management strategies and outcomes. This study, published by you and colleagues a number of years ago, was a randomized controlled study in valvular heart patients. They were randomized to receive either IV iron and erythropoietin or placebo. So in these two groups, the endpoints they looked at were transfusions up to 4 days and reticulocyte counts and iron levels. In this randomized controlled trial, you can see that there was a small but impressionable impact on hemoglobin levels in the iron and erythropoietin groups versus the control group or the placebo group. And out to postoperative day 7, note that hemoglobin levels were appreciably larger than at baseline or in the control group. Notably, more impressive are the reticulocyte counts, which started to dramatically increase at postoperative day 7. And we know what this means. This means a smoother recovery. This means that when the patient goes home, their retics are still active and they're creating new red blood cells so that they can restore a hemoglobin level that may have been decreased as a result of cardiac surgery. And this is a signal that we're going to see frequently as we look at a little more literature. In this study, also note that patients in the iron and erythropoietin groups received fewer intraoperative red blood cells, fewer red cells on postoperative day 1, 2, and 3 to 4, both in the number of units transfused and in the percentage of patients that received a transfusion. Another study by Donat Spahn in patients that were randomized, and they were stratified by the type of surgery that they encountered. There was anemic and iron deficient patients were included in this randomized controlled trial. And what Dr. Spahn did was he gave a cocktail of medications to treat anemia. So iron, erythropoietin, and folate and B12. And he randomized with a control group. 24 hours before surgery, this cocktail was given, so we don't need a large lead time. And notice that in this EPO or cocktail group, the significant results were evident. Patients received fewer transfusions out to day 7, and the total red blood cell acquisition costs as a result of those transfusions was lower in the treatment group. Now you'll notice that the total acquisition costs were larger, and these are in Swiss francs. The total acquisition costs in the treatment group were larger because of the erythropoietin treatment. And I would put out to you that not all of these patients needed erythropoietin. IV iron itself is often enough of a stimulus, especially in patients with pure iron deficiency. But these patients were not strictly evaluated for what they needed based on their specific anemia. They were all treated similarly, and therefore the acquisition costs, if erythropoietin is involved in all of your treatments, can be quite high. This is a very fascinating study in my mind, because a lot of the reason why we don't treat preoperative anemia in cardiac patients is because we say that we can't wait the week or two that it might take for iron and or erythropoietin to start to take effect. Well, this study administered isomaltose or Monifer intraoperatively, a single dose of 1,000 milligrams. And patients undergoing cardiac surgery were randomized to have either a single dose of iron intraoperatively or a placebo. These were non-anemic patients. So as you can see in the graph on the side, their results show the patients were non-anemic. They dropped their hemoglobin level during surgery, and they recovered to a much greater degree, 12.7 versus 11.6 after surgery. And this is a demonstration that iron therapy is beneficial to many patients, whether they're anemic or not, and whether they're iron deficient or not. The reason for this is that all patients become iron deficient on cardiopulmonary bypass. They may not even be anemic. Even if they aren't anemic, the state of iron deficiency, especially at the level of the myocardium, is exacerbated by cardiopulmonary bypass. And this is something we can't measure, myocardial iron stores. So suffice it to say that in many of these trials, iron treatment has been administered with positive results and very few, if any, adverse reactions. So following that up, a randomized controlled trial in non-anemic patients was conducted and published last year by Friedman and colleagues. And they took patients who were having cardiac surgery without anemia, randomized them to receive either ferric carboxymaltose, 1,000 milligrams, either 1 to 3 days before surgery, or a placebo. Their primary outcome was red blood cell transfusion 4 days post-op. They had other secondary outcomes as well. And note that in this randomized trial, the primary outcome was met. In the iron group, there was a statistically significantly lower number of red blood cells transfused out to 4 days post-operatively. There were also a number of other significant findings. The hemoglobin levels at post-op day 4, at 4 to 6 weeks post-operatively. This is a very impressive result, because many times we transfuse patients, or it is said that patients are transfused so that they can feel better. They're weak and they don't want to be sent home in this weakened state. Well, the administration of iron while in the hospital allows that patient to fabricate red blood cells over the ensuing weeks and to create a larger hemoglobin store and level during recovery. And this is critically important for us in the perioperative period. Even in the subgroups that Friedman and colleagues analyzed, all of these specific subgroups had a better reaction and a lower transfusion rate at that postoperative day 4 in the iron group than in the placebo group. So most subgroups benefited statistically significantly. The Euroscore groups, the males, BMI, and other types of subgroups analyzed. So IV iron should be considered, and it's impressive in my mind that this can even be given on the day of surgery. What about the number of units that are administered? We heard earlier this morning, I think Dr. Friedman mentioned, why give 2 when 1 will do? And this has been a great adjunct to patient blood management. If every time we gave a single unit rather than 2 units, as we've been taught, we would significantly reduce transfusions. But is a single unit even indicated when we transfuse? And this is a really fascinating study published by Natalia Girardi and colleagues out of Cornell, where they analyzed the STS, the Society of Thoracic Surgeons database, a gold standard database, a now public reported database of all centers in the United States. And between the years of 2010 and 2019, they were able to acquire 2 million data points of surgical procedures. From the database, they evaluated patients who were transfused and not transfused. So of the patients that were transfused, there were 847,000. They looked into those that were transfused only 1 unit. So that left them with 206,000 patients for comparison. They then propensity matched these single unit transfusion patients to patients that received 0 units. And a careful propensity matching process yielded 206,555 pairs. Incidentally, I can share with you that those patients that received a single unit were more often female, more often small body surface area, and non-white. And they ended up having a higher mortality and morbidity profile, which I will show you on the next slide. So the single unit transfusion patients had a higher mortality, operative mortality, a higher stroke rate, more infection, prolonged ventilation, new hemodialysis, and reoperations. So this is suggestion that transfusion itself, even in a small aliquot, like a single unit, may portend and be a risk factor for adverse outcomes. Now, of course, this was a propensity matched database study. There may have been some confounders that were not recognized in these patient population profiles, but this is really an intriguing discussion point for future practice. Transfusion does predict infectious outcomes. There are numerous data points, numerous studies of retrospective trials and even prospective trials indicating that transfusion is a marker for an increased risk of infection. And our earlier speaker, Dr. Freeman, mentioned this as well in its immune suppression ability. Transfusion can be a risk factor for increased infection. So this study, published by Mike Mazzeffi and colleagues a couple of years ago, demonstrates this very nicely in a large population. Also, the STS database was queried for a 3-year period. And out of roughly 300,000 patients, they analyzed a subset who were transfused red blood cells. And that was 59,000. This was CABG only. So this is actually a really impressive result. In and of itself, only 16% of isolated CABG patients received any transfusion. That's something that centers that transfuse liberally should really aspire to on the way down to no transfusion. So out of these 16% of these CABG patients, they divided the patients by the number of units that they were transfused. And note that most patients received only 1 or 2 units. About 75% of all of these patients that received any transfusion received 1 or 2 units. Also calling into question whether or not that single unit was really indicated and if it conferred any harm. In their results, they conducted a mixed effects logistic regression model, taking into account many factors, many preoperative factors, the preoperative risk score, which is shown on the x-axis, and the probability of hospital-acquired anemia, which was a composite of sepsis, pneumonia, and wound infection. And note that as the STS risk score increased, the risk of a hospital-acquired infection also increased. But even more predictive of an increased risk of infection was the number of units that were transfused, with 5 or 4 or more units shown in the orange line being the most predictive of hospital-acquired infection. And similar to this result, we conducted this study at my institution. Dr. Lee and our group looked at our single center STS data. And over a 4-year period out of 2,500 patients, we looked at risk factors for adverse events like prolonged ventilation, infection, renal dysfunction, and others, and mortality. And in careful univariate analyses, we eliminated the factors that were confounders and came out with a multivariate logistic regression that indicated the risk factors for our adverse outcomes. We had final logistic regression models that indicated that red blood cell transfusion volume was an independent predictor for all of these adverse events. And to the effect of, for each additional red blood cell transfused, there was about a 1.5 increased risk for each unit. There was a 1.5 times risk of a prolonged ventilation event. Other risk factors were total platelets transfused, BMI, and time spent on cardiopulmonary bypass. And a similar result for infection, which is what we're talking about. As each individual unit is transfused, the risk of an infectious outcome is increased by a 1.5 times nearly. Similarly, platelets and low temperature were contributory to the infectious outcome composite. So we are striving for zero transfusion. Clearly, every unit that we give increases the risk of either an infectious outcome or a prolonged stay in the intensive care unit. So moving away from anemia management, I'd like to now talk about algorithms and transfusion strategies. Transfusion algorithms, as they are called, are really algorithms that are designed to treat bleeding. So we can call them bleeding algorithms or hemorrhage algorithms. In the interest of time, we certainly cannot go through all the studies. There's thousands. Even if you go through all the randomized controlled trials, there really is not the time. So let me see if I can encapsulate for us what point of care algorithms have done for the management of patients having cardiac surgery. It's a class 1 indication in the STS-SCA guideline from 2021. Goal-directed transfusion algorithms which incorporate point of care testing, such as with viscoelastic testing, are recommended to reduce peri-procedural bleeding and transfusion. Note that it says such as with viscoelastic devices. So it doesn't matter where you practice and what you have on board. You really need not have a fancy viscoelastic device. Any sort of testing whose results come back in relatively rapid fashion can be used to organize a management strategy for bleeding. So pictured here are some of the viscoelastic devices, and pictured here are some of the algorithms. But again, there are algorithms that don't really use viscoelastic parameters. There are algorithms that use laboratory parameters. I understand we're all limited by the turnaround time of some of our laboratory values, but anything we can do to rationally look at the coagulation and platelet function is better than an empiric approach to bleeding. So to encapsulate these data for us, I will introduce us to a meta-analysis of all the viscoelastic studies that have been conducted up to 2020. And this study by Mecco and colleagues indicates, as you would expect, that all transfusions are reduced in the viscoelastic testing group. Red blood cells, platelets, and plasma. Similarly, outcomes are also measured in bleeding. So if you look at chest tube drainage, you can see that in the viscoelastic testing versus control groups, even chest tube drainage is reduced. And here we are at outcomes. Reoperations, a critically expensive and morbid outcome, is reduced in viscoelastic testing groups because we more appropriately treat the defects, and we can postpone or eliminate reoperations for bleeding. And length of stay has also been positively impacted. Mortality, not statistically significantly, and this is expected. One would not expect a single intervention to have an impact on overall mortality in cardiac surgery. So we've talked about anemia management, the need for anemia analysis and the treatment of iron deficiency, or anemia of inflammation, or a macrocytic anemia in the preoperative period. Patients presenting with higher hemoglobin levels do better and often have easier recovery after cardiac surgery. The preservation of coagulation. One thing we did not mention in the interest of time was antifibrinolytic therapy, a class 1 indication in cardiac surgery to reduce bleeding during the cardiopulmonary bypass period. Algorithms and hemorrhage treatment strategies, as we just discussed, are very important in reducing transfusions and hopefully getting us to our bloodless state, our zero transfusion state. So the results of fewer transfusions and zero transfusion would be fewer adverse outcomes. We see less infection, less prolonged ventilation, and shorter ICU lengths of stay. So in summary, to accomplish bloodless cardiac surgery, we must practice patient blood management. It is a critical component of bloodless medicine. So patient blood management informs the recommendations that are in our guidelines, and it stresses the importance of evidence-based multimodal and multidisciplinary approaches to native red blood cell preservation, coagulation dysfunction management, and protocol modifications to improve outcomes for all of our patients, specifically directed to the cardiac surgical patient. So I would like to thank you for this really incredible honor. SABM has been very honored to be associated and collaborative with the Bloodless Medicine and Surgical Society. We really appreciate our opportunity to be at the BMSS. And I'd like to invite everyone to the SABM meeting next year. It'll take place in Minneapolis, Minnesota from September 18th through 20th. And I look forward to seeing everyone there, everyone who is able to attend. Thank you very much for this opportunity.